It's 8 o'clock. Good evening, everybody, and welcome to another episode of Marvelous Medicine. I have great pleasure in having Dr. Ankur Gupta again. He's the Regional Director, Medical Affairs at Menarini Asia Pacific, Singapore. He did his MBBS from GMC Amritsar and MD Pharmacology from CMC Ludhiana. He has extensive experience in the pharmaceutical industry in medical affairs and medical marketing. He has developed expertise in infectious diseases with focus on antibiotic stewardship. He has delivered over 350 lectures across the globe on rational use of antimicrobials. Ankur's special interests are devising patient-centric, physician-friendly solutions and clinical decision support systems. Thank you, Ankur, for accepting to give this talk on very short notice.
Thank you so much, ma'am.
Moderating the session will be Dr. Ram Gopalakrishnan. He's the Senior Consultant, Institute of Infectious Diseases, Apollo Hospitals, Chennai. He did his MBBS from Madras Medical College and MD Internal Medicine from PGI Chandigarh. After doing his MRCP in UK, he proceeded to US to do his internal medicine residency in Texas and did his fellowship in infectious diseases in Ohio. Dr. Ram Gopalakrishnan is the Adjunct Professor, Tamil Nadu MGR Medical University, and Adjunct Professor at Apollo Hospitals Education and Research Foundation. He was the Chairman of Treatment Guidelines for Anti-Microbial Use in Common Syndromes project of ICMR in 2019. He has 76 journal publications, 5 book chapters, and has delivered over 250 invited lectures. Thank you so much, Dr. Ram Gopalakrishnan, for accepting our invitation, and I thank Ravi Shankar for putting me in touch with you. Joining him as moderator will be Dr. Reba Kanungo. She's adjunct faculty at KMC Mangalore. She did her MBBS from SCB Medical College, Cuttack, and MD and PhD from JIPMER, Pondicherry. She was a former Dean, Research, and a Professor and Head of Clinical Microbiology at Pondicherry Institute of Medical Sciences, and before that, Professor of Microbiology at JIPMER, Pondicherry. She has provided technical assistance to NACO and SACS through US government partnership with Government of India, Ministry of Health and Family Welfare. Dr. Reba was a past president of Indian Association of Medical Microbiology and was awarded the H.I. Jhala Memorial Award for contribution to microbiology at the national level. She has 148 publications and has recently released the 12th edition of Anantanarayanan and Panikar's textbook of microbiology for undergraduates, which she edits. Thank you everyone for joining us, and over to you, Ankur.
Thank you so much, ma'am. Before I proceed, how much time I have?
40 minutes, 45 if you need.
Sure, thank you so much. So first of all, once again, I thank Dr. Vidya and all the organizers for inviting me again. I think exactly after 14 months, I think the last time was January 2021. Today I'm a little bit nervous, and especially only because of RGK sir being here. You know why I'm saying this? Because I have no special expertise in infectious diseases. I am a clinical pharmacologist. I belong to pharmaceutical industry, but I promise today I'll be wearing my hat purely as a person who's passionate for antibiotics and who's a clinical pharmacologist. Now, before going into the journey of antibiotics, why I also feel unqualified to talk about this topic is because when I was doing my MD pharmacology, like most of the pharmacology students, we did not pay much attention to infectious diseases. We were told that cardiovascular, CNS, and ANS are the 3 chapters which are asked in the final exam. In antibiotics, you only have to learn about anti-tubercular and anti-malarial drugs. So when I passed my MD pharmacology, I hardly knew the names of 5 antibiotics. You know, so that was my knowledge in 2006 December when I passed my MD in pharmacology. But as the luck would have it, my first interview in pharmaceutical industry and my first boss, he asked me, the first question was, what is an ESBL? And I was at 6s and 7s. I said, what is this? Is this a country? Is this a pathogen? Is this, what is ESBL? So that is when I heard for the first time in 2007 March, what is an ESBL? And since then, I have been eating, drinking, sleeping antibiotics as my career took. I was responsible for antimicrobial stewardship when I was with MSD. I could travel entire globe and talk about stewardship. And although belonging to pharmaceutical industry, but somehow I kept my passion which was product agnostic only on the rational use of antibiotics. So that is a little bit of my association with this special class of drugs. Let me just share my screen. As I share my screen, let me tell you, about 10 years ago, can you see my screen, ma'am? Okay. So about 10 years ago, WHO did a polling that which is the class of drugs which has saved the maximum lives on this planet. You know, which is the biggest medical discovery. So the biggest medical discovery of the previous century was X-rays, and number 2 was penicillin. Right now, penicillin was first used as we see the Ukraine-Russia war, and we are at hopefully not at the cusp of the Third World War. The first time penicillin was used was in the Second World War, when the soldiers were dying of gunshot wounds, probably because of the Staph aureus infection, and we did not have anything. And then the Merck company was asked to produce penicillin en masse and give it for free for the soldiers to be treated. Okay. And just see how last 70, 80 years have progressed, that now WHO is saying that after the year 2040, which is just 18 years from now, there is a real scare that we may be entering the post-antibiotic era. So from the pre-antibiotic era of 1940s, before 1940, to post-antibiotic era, this class of drugs has come a full circle. And that's why my topic for today is antibiotic resistance. Have we reached the dead end? The pioneers of antimicrobial stewardship in India, like RGK sir and some of the passionate people like myself, have been talking about resistance, about stewardship for last so many years. I remember when I joined, when I started talking about stewardship, there were very few people who were interested in it, and especially Western speakers. When I used to go to Europe or US, they used to say, look, this is a third world country problem, right? But now, after especially what we have seen, the Carbapenemises having swept across the globe, now this has become an international issue. And I think the way we have used antibiotics in our COVID, especially in the second wave, the way we have used azithromycin, doxycycline, and meropenem in the ICUs, I am sure our resistance rates have shot up. So what I'm going to talk today about is the death of antibiotics. Is that a real scenario? Is there a silver lining somewhere? Is there light at the end of the tunnel, or have we reached the dead end? So this is what I would like to talk about in the next 30 minutes. What is AMR? How is India the worst affected? The mechanisms. I would like to keep it simple and not go into too much of technicality. What are the risk factors, stewardship guidelines, and what we can do in terms of antibiotic command? So simply, antibiotic resistance basically is, as one of my teachers, Dr. Camilla Rodriguez from Hinduja Hospital says, the more you use them, the more you lose them. You know, what is the side effect or the collateral damage of driving a car? Air pollution. Similarly, the collateral damage of using an antibiotic is you lose it. So when you use an antibiotic, antibiotic resistance will happen. The question is not if, the question is when, right? So we just can delay it, slow its onset, and reduce the progression. So this is a societal resource between, and there is a balance that we have to maintain between the individual patient and the society. You know, because this is a routine logic given by physicians that, look, I have to save the patient in front of me. But what we forget is that you may have to pay the price for the misuse of antibiotic in a particular patient. The society has to pay by increased resistance, cost, and other things. So this is a tightrope walk between use, overuse, and abuse of antibiotics. So what is the selection of resistant bacteria? How it happens? It simply means in the nature, there are mutant strains which are just generally present. As you can see in the circle on the left, the bacteria with the red dots is a mutant strain which is present in the nature. When you give an antibiotic, the sensitive strains die. The patient is cured of the infection because the resistant strain is in lesser quantity. Patient goes home. But once the sensitive strains die, nature abhors vacuum. So this resistant strain which is now left ultimately propagates and passes on this resistance gene to the next generation and creates its own type. So now this patient's flora has been replaced by a resistant strain. So next time when the patient gets an infection, it would be because of a resistant strain, and the same antibiotic might not work. So basically, there are only two broad definitions or guidelines, or should I say concepts, regarding resistance. One is selection pressure. So this is a classical case of selection pressure. The pressure of antibiotic use has caused a resistant strain to be selected out, which then propagates, produces its own type, and this is how the resistance spreads. The second way the resistance spreads is collateral damage. You know, our body flora is full of bacteria, but they live in symbiosis with the body. Now, what is collateral damage? Suppose a patient is having these flora in the body, and you give an antibiotic to kill the bacteria which is causing an infection, but that antibiotic does not distinguish between the normal flora and the causative pathogen. So even the normal flora or the commensals in the body also taste that antibiotic, and in a way prepare themselves to fight against this antibiotic in the future. So this is known as collateral damage, that you wanted to kill a pathogenic bacteria, but you're also putting a pressure or an effect on the bacteria which were there only present as a commensal. So broadly, selection pressure and collateral damage are the two concepts driving antibiotic resistance. Now, we all know this issue is now very hot. There are very few drugs in the pipeline, and I'll give you a brief glimpse of the pipeline coming from pharma industry. And as I said, delay what is inevitable as long as possible. You cannot stop resistance, you can prevent it, you can slow down. Now, look, what is coming from pharma industry, I can tell you this is a game of diminishing returns, right? Till 1980s, I remember 60s, 70s used to be called the golden age of antibiotics. You had whole amoxicillins, the cephalosporins, fluoroquinolones started coming up. And one of the US Surgeon Generals in 1969 said, by the year 2000, we will close the book on antibiotics. So just imagine that, the euphoria that was created by antibiotics. But it slowed down by 80s when the resistance started spreading, and the pharma industry focused its attention towards the high yield markets of cardiovascular drugs, hypertension, depression, psychiatric drugs. And after 80s, 90s, there was very few drugs. Okay, so as you can see, in the last 20-30 years, the overall spend on antibiotics by pharma industry has come down, because it takes 10 to 15 years to develop one drug, and bacteria might just go for single mutation and your antibiotic is gone forever. Okay, so that was the reason that these are not the money spinning cash cows for the pharma industry. And the biggest pathogens, the acronym that we used is ESCAPE. Okay, no escape, Enterococcus, gram positive, Staph aureus is gram positive, and the remaining 4 are gram negatives, which is Klebsiella, Acinetobacter, Pseudomonas, and Enterobacter species. Now, it's important to remember these terms because we use them interchangeably: MDR, XDR, and PDR. What is an MDR? A pathogen which is resistant to 3 or more classes of drugs. XDR, which is resistant to everything except 1 or 2 classes, and PDR is which is resistant to everything. So how do we give an example for this? So classical MDRs are your ESBLs, extended spectrum beta-lactamases, enzyme produced by E. coli and Klebsiella, which makes all penicillins, all cephalosporins, monobactams resistant. So you can see 3 or more classes of drugs are resistant. Similarly, MRSA in gram positive. XDRs are classically carbapenem resistant pathogens. These are resistant to almost everything, only susceptible to a colistin, a TG cycline, a phosphomycin. And this is the biggest bane of our critical care setups, of our oncology units, of our immunocompromised patients, are the XDRs today. Okay. Now, I thank Jim O'Neill. Now, this paper created a revolution. I can tell you why. 2014, this was Jim O'Neill. He was not a scientist or a infectious disease physician. He was a banker. He was with Goldman Sachs. He was an economist. And the then British Prime Minister, David Cameron, asked him to produce a review on antibiotic resistance. And this was the first time the world understood resistance beyond science, in terms of money, in terms of lives lost. So he made an estimation that by the year 2050, if we do not do anything, 10 million people might die of AMR, which will be more than diabetes and cancer put together. And I think, as we know, money talks. He said, if that happens, the world will lose about 3% of GDP and $100 trillion. And I know what impact this paper had, that after 2 to 3 years of this paper, even in the UN General Assembly, there was focus sessions of antibiotic resistance. Okay, so many people say this paper is alarmist, but I think it's for the first time asked the word that you can no longer put this problem under the carpet. 2017 WHO said we have 3 major critical pathogens for which we need drugs, which are CRAB, which is carbapenem resistant Acinetobacter baumannii, CRPA, carbapenem resistant Pseudomonas aeruginosa, and CRE, carbapenem resistant Enterobacteriaceae. So these are our biggest issues, especially in Indian setup also, and I'll be talking more about this. Now look at this latest paper, just came 2 months ago in the Lancet, one of the most prestigious journals, the global burden of antibiotic resistance. And look, unfortunately, where is India? Now look at our MRSA rate, gram positive. When I used to be in India and we were saying that India, we have a problem with gram negatives. We don't have gram positives. Look at our gram positive rate is also 50% plus our MRSA resistance. Why we say MRSA or gram positive is less of a problem? Because our gram negative is 80 to 90%. But that does not mean we don't have a gram positive problem. So our MRSA rates are very much in excess of 50 to 60%. Esbls, we have been the world champions for the last 20 years. Our Esbls rates now in the hospital setup have crossed 70 to 80%. Even in the community setup, we have publications now for smaller cities, Kanpur, Nagpur, Pune, 40 to 50% of the community samples are Esbls. And this is the most worrisome aspect. And ESBL is a vicious cycle. As the ESBLs rise, drug of choice we know for sick patients is carbapenem. More you use carbapenem for ESBL, more you lose carbapenem, which creates carbapenem resistant pathogens. And that is exactly what has happened. Look at our CRE rates. Again, unfortunately, we are the world leaders in CRE with rates of excess of 50 to 60%, right? And we have to break up CRE, as I will discuss later, and CRAB. I think this is one pathogen which is not very virulent. It's just that it has become multi-drug resistant. It's a common pathogen in the ICU environment. It loves moisture. You can see it in the sinks, behind the curtains in the hospital. But because of the antibiotic pressure, this has become resistant. And across the globe, barring Australia, some Scandinavian countries, the CRAB rates are in excess of 50%. In India, this rate is about 80 to 90%. And this is the data I got for the rest of the Asia Pacific region. See how India is different from China or rest of the world. ESBLs more than 70-80%, carbapenem resistant Pseudomonas is 50-60%, and CRE, carbapenem resistant Klebsiella E. coli. When we talk of CRE, and I'm now going to a little bit of detail, we have to divide CRE. Because CRE can be because of KPC, which is an enzyme, OXA48 enzyme, or MBL, which is metallo-beta-lactamase enzyme. Now, why this is important to know? Because the new drugs which are coming are specific to these enzymes. How India is different, our major CRE enzyme is MBL, metallo-beta-lactamase, for which there is hardly any new drug which is coming. Whereas for KPC, which is the predominant CRE in US and some of the European countries, there are now 4 new drugs. Okay, so this is important, and I will cover that in the management part. Now, it does not surprise us that India ranks one of the highest in terms of antibiotic consumption. Look at the change in the 10 years from 2000 to 2010, our antibiotic consumption. And that is the reason. And see, when I say, now this is a real life scenario, what happens? And I have written that ignorance is not a bliss. I was in one Delhi government hospital. This is way back in 2012, I think. I went for a lecture to a government hospital and asked, what is your ESBL rate? One of the doctors stood up and said, Dr. Ankur, we don't have ESBLs in our hospital. I said, well, that's great, but what's the basis of this statement? He says, our microbiologist never tells us if it's a ESBL or not. I said, sir, absence of evidence is not evidence of absence. Okay? Simply because your microbiologist does not tell you, it does not mean you don't have ESBLs. Can you show me what data you have? So he gave me this one sheet. And I said, look, what is happening in this hospital? They are sitting on a volcano. CI is ceftriaxone. E. coli and Klebsiella, 89% were resistant to ceftriaxone in this hospital, which is a surrogate marker. They were ESBLs. So even if your microbiologist does not tell you, you have to know how to read a culture report, how to fathom whether this particular pathogen could be ESBL or not. So ignorance is definitely not in place. If you're working in the critical care setup, you have to know the microbiology. That is the reason antibiotic in India, I say, is in state of antibiotic anarchy. Our hospitals are not conducive for antibiotic protocols. Very few qualified ID physicians. I remember this was a game we used to play when I was in business, that let's count how many ID physicians in India we have. And when I was there, there was hardly 30, 40. Now I think it's a 60 or 70. So, but that's it. For in US, I think there are more than 5,000 ID physicians, right? So we can't work with only 60 ID physicians for 1.3 crore people, right? So plus pharma industry has its own nuisance value. Why should there be 250 meropenams, 500 piptazos generics from 50 rupees to 2,500 rupees, and then there is an indiscriminate promotion to the GPs? It pains my heart to see when GPs write meropenem 500 mg BD for typhoid fever, or I see drugs like ferropenem being used as an oral carbapenem, right? So this is what the contribution of pharma industry, and there is no doubt now that, look, our resistance rates are one of the highest. And I asked one of the hospitals that, can you do a small thesis for your PG students? Just check 100 discharge summary and see out of 100, more than 90 discharge summaries will have an antibiotic. That's why I say antibiotic is automatic along with the antacid, multivitamin, maybe an NSAID, there will be an antibiotic in the discharge summary. So that's the situation we have landed up, and that's the reason why India has unfortunately become the antibiotic resistance capital of the world. Okay. Now, the next section is, what are the mechanisms? How do these bacteria, microorganisms, they have mastered the art of survival of the fittest. They have inhabited this earth much before us. 2 billion years ago, we have just come 10,000 years ago, and we have been using antibiotics only for 70 years, right? So without going into much technical detail, I think we have to know that there are classically 4 mechanisms of resistance. One is beta-lactamase production, which means bacteria produce enzymes which destroy the beta-lactam ring in the beta-lactam antibiotics. And beta-lactams are one of the most commonly used antibiotics. All penicillins, all cephalosporins, carbapenems are examples of beta-lactam antibiotics. So bacteria which produce enzymes which break this beta-lactam are known as beta-lactamase production. Second is Porin loss. What is Porin loss? These green oblique circles that you use, these are like entry channels for antibiotic to enter the bacteria. These are known as porins. So what bacteria do? They close this channel. They close the gate, entry gate, so my antibiotic now cannot enter. This is known as Porin loss. Very common mechanisms in gram-negatives like Pseudomonas acidophilus and Klebsiella. Third is alteration of target site. This red color cubicle shape, this is suppose the final target where my antibiotic has to attach. It could be a protein, it could be a cell wall. But as my antibiotic was approaching, this changes its site. So now my antibiotic, like a lock and key, cannot attach. This is a very common mechanism of resistance in gram-positive. And finally is efflux pumps, which you see are these blue structures. What is efflux pump? Even before the antibiotic has attached to its target site, these are like motor pumps which exit the antibiotic, which push the antibiotic out of the bacteria. So this is again very common in Klebsiella and Pseudomonas and other bacteria. So these are the 4 major mechanisms of resistance by which bacteria become resistant. Now I will talk a little bit about beta-lactamase, and again this is very technical. Microbiologists, pharmacologists might know this, and of course IDs. But why this is important is because our drugs are not targeted towards specific enzymes. So this is the most common and simpler classification of beta-lactamases called Ambler classification. We call it class A, B, C, and D. Class A is classical beta-lactamases and Esbls. Class C is MC. Class D is OXA. And class B is the most dangerous, which are NDMs, IMS, which are the metalloenzymes, which makes carbapenems resistant. Now, I have made this summary slide, and I know it's very, just to explain this one slide, it needs 20 minutes, but I'll just leave it here. But what this slide tells us is, in case I have put this slide on my study table, it's a ready reckoner. 4 types of beta-lactamases, starting from the simpler ones, classical, next bigger one is Esbl, next MC, and next carbapenems. What are the different types of enzymes? Second column is which bacteria produce them. Third column is which antibiotics are rendered ineffective because of these enzymes. And fourth is which are the drugs of choice for these different enzymes. So if you focus your attention on the last row, which is Carbapenemises, which is the biggest problem these days, they destroy all carbapenems and all beta-lactams. Most commons are KPC, MBLs, OXA. And what do we use for them? Polymyxin, colistin, we combine with digicycline or phosphomycin or estrionam. So we throw the kitchen sink at this. And that's the most troublesome class that we are working with today is Carbapenemises. Just remember these names: KPC, OXA, and NDM. Three most important Carbapenemises, because when we'll discuss solution, we have to remember the names of these different enzymes. Now, I remember as a physician, as a student of science, when we were doing our MBBS, we were never taught of risk stratifying the patients based upon the risk of resistance. Risk stratification of patients was always done based upon the clinical risk. You know, his blood pressure, his requirement for ventilation, his requirements for fluids, oximeter. But what about the risk stratification for an MDR? Suppose a 25-year-old young person had a road traffic accident, had a head injury, went to the ICU. Why he should be given meropenem? I know he's very sick, but simply because he's in ICU and he had a road traffic accident, he should not deserve an antibiotic, right? So there should be some method in the madness which should tell us whether my patient is at risk of a resistant pathogen or a sensitive pathogen. That will help us to use our empirical antibiotics correctly. Most of the misuse of antibiotics happen empirically. Why? Because culture takes at least 48 hours. And I think 5 years, 10 years from now, like we check from a finger prick, hemoglobin report is given in 5 minutes. I hope there is a technique which can give us whether it's a resistant pathogen or not within 5 minutes. A lot of resistance and unnecessary antibiotic use will go down. But till that happens, we have to use our empiric antibiotics correctly. And one of the major factors to know is which factors make my patient more susceptible to acquire resistant bacteria. And there are basically three. One is patient's own characteristics. Older patients, patients with comorbidities, diabetes, hypertension, renal disease, immunosuppressed patients, malignancy, organ transplantation. These are all patients which make them susceptible to be affected by a resistant bug rather than a sensitive bug. Second is where the patient has come from epidemiology. If the patient was already in the hospital or shifted from another nursing home or coming from an epidemiological area with high resistance rates, they may have resistant pathogens. Next is patient's exposure to antibiotics. In the last 3 months, has the patient been exposed to antibiotics? And finally, patient's prior history of hospitalization or catheterization or any instrumentation which has been done. So all these risk factors, if I have to combine and shorten into 3 broader types, just for our remembrance. One is contact with healthcare system is one of the major risk factors. Second is antibiotic treatment, history of antibiotic treatment. And third is patient characteristics. I think a proper history taking when the patient arrives in your hospital. For example, a young patient, 30-year-old coming with consolidation on X-ray, history of fever and cough. Most common diagnosis, community-acquired pneumonia. Most common pathogen we are suspecting is strep pneumonia. But if the same patient is a 70-year-old chronic smoker, already had an episode of UTI for which he was admitted in the hospital 2 months ago, now has come with community-acquired pneumonia, I am not only suspecting a plain simple strep pneumonia. It could be a resistant strep pneumonia, it could be Klebsiella, it could be a resistant pathogen. That is how the difference makes that whether I will use empirically an amoxiclav or I will use a piptazo or a carbapenem. It does not depend here on the patient's clinical severity, but the risk of having a resistant pathogen as my empirical drug choice. So for me, that's very important because that's where most of the misuse happens. And that's why, you know, when we were in business, we created this very simple, some call it simplistic, but I think this is a good way to start. We divide the patient type 1, type 2, and type 3. So type 1 patient, no history of healthcare contact, no procedures, nothing in the last 90 days, young patients, you are not suspecting a resistant pathogen. There is no need for broad spectrum antibiotics in this patient. Patient type 2 is a ward patient. maybe an old patient, maybe had some procedure or a short course of antibiotics. Now he comes to your hospital or your OPD. Maybe he has a risk of Esbls or MRSA. Try to give him non-pseudomonal, less broad spectrum drugs. And patient type 3, who has had multiple healthcare contacts, invasive procedures, maybe catheterized, had an antibiotic course, immunocompromised, any one of these, this is the patient you need to take immediate care, because this patient might go into sepsis or may have resistant bacteria. Here you give a bigger, broader, newer antibiotic. So I think one basic level of filter that which can apply is this risk stratification, which can help us to reduce the misuse of antibiotics. Okay, so I have talked a lot about the problem, about the causes of the problem, how to identify it. Now let's see how we can manage it. I am one of the optimist brigade. I still think we have not reached the dead end. We can make a U-turn. Okay, and that is antimicrobial stewardship. And for the critical care in the ICU, the mantra of antibiotic stewardship is Virender Sehwag mantra: in early, hit hard, out early. So when you have a sick patient in the ICU, we know all from the sepsis guidelines, the first hour is the golden hour. So we enter early, right? We give the first shot of the antibiotic as soon as possible, as soon as we suspect the patient is having sepsis. We hit hard. We don't we are not conservative on giving the highest possible dose. The first dose of an antibiotic should always be the highest possible dose. And being a pharmacologist, I will talk more about it, but this is very important. And then out early. The moment the patient's clinical condition is improving and you are getting the culture reports, day 2, day 3, day 4, you need to reduce on the either the duration or the number of antibiotics or the spectrum of antibiotics. That's the overall formula that we apply in early, hit hard, out early for the antibiotic treatment. Okay, some principles of antibiotic use in surgery, generally because I'm talking to a surgical audience, is use, choose, stop, but also switch. Okay, so what are some of the characteristics in using the antibiotics? First of all, to decide who needs an antibiotic. Prophylaxis. Yes, prophylaxis means giving the antibiotics just at the time of induction, not 24 hours before, not 2 days before. I think most of us now follow this. Single shot before the surgery, and maybe, or if the patient is in sepsis. These are the conditions we need to think. Not all fevers are because of infection. As someone says, fever is not a sign of ceftriaxone deficiency, or these days piptaz or a carbapenem deficiency. Second, for surgeons, has the source been controlled? If it's an abscess, you can give antibiotics for eons together, it will not be controlled. We have to take care of the source first. Dose and dose adjustments. And this is very dear to me, being a pharmacologist. The first thing we do when the creatinine goes from 0.6 to 0.8 is reduce the dose. Bacteria love low dose. It's a recipe for them to become resistant. Okay, so we have to know, and I can tell you, even in my MD days, we were only told this classification of antibiotics: broad spectrum, narrow spectrum, bacteriocytic, bactericidal. We were never told something called time-dependent antibiotics for a concentration-dependent antibiotics. This is a very important classification. Okay, time-dependent. So I'll give you a little bit on this. And so, what are time-dependent antibiotics and concentration? Concentration-dependent antibiotics are those whose efficacy depends on how high you can go above the MIC. What is an MIC? Minimum concentration needed to inhibit 90% of bacteria. We call it MIC 90. So for concentration-dependent antibiotics, higher the Cmax, which means the maximum concentration in the body, as compared to the MIC. And this ratio is 8 to 10, but even if you forget it, just remember fluoroquinolones, aminoglycosides are concentration-dependent antibiotics. Whereas beta-lactams are time-dependent antibiotics. It does not depend how high you go above the MIC, but how long you remain above the MIC between the two doses. That is known as time-dependent antibiotics. All beta-lactams are time-dependent antibiotics. Now, this is theory. Let's see what happens. Suppose you are giving meropenem in a 30 minutes infusion. This is the time, just the time that it remains above MIC and it is effective. But the same meropenem, if you give in a 3 hours infusion, remains above the MIC for this additional duration. And now we have evidence to show that if we optimize PK/PD, there is higher efficacy. So now we say, whenever you are using PK/PD, beta-lactams, especially in a critical care setup, give them in a prolonged infusion. Now, this is theory. How to learn in practical? For time-dependent antibiotics, you give frequent doses. You can't give peptides or carbapenems 8 times a day. That's not practical. So next possible is give them in a prolonged infusion. Remember, carbapenems should not be given more than 4 hours infusion because they are unstable. Peptides can be given up to 6 hours, and other beta-lactams can be given longer for the prolonged infusion. And this is mainly for the critical care patients. For concentration-dependent antibiotics, give single shot or maximum 2 shots in a day. Gone are the days when amikacin was given 5 mg per kg 3 times a day or 4 times a day. The right dose for amikacin is 1 gram once a day. Right? Will it increase nephrotoxicity? No. Nephrotoxicity does not depend upon peak levels or the trough levels. Right? Longer aminoglycoside stays in the body, more is the nephrotoxicity. So if you give in a single shot, it reaches its maximum, kills maximum bacteria, exits the body. So it's good for the body in terms of efficacy and also safety. So I think this is very important to understand how to use our antibiotics. So I'll say PK/PD makes good drugs look even better. So the same drug in a normal dose versus a high dose can work better. Timing of starting antimicrobial therapy is very crucial. I said for sick patients, first hour is the golden hour, especially for septic shock. Prophylaxis within 1 hour before the operation, mostly at the time of the induction. Prophylaxis, I have to talk a little bit about it. 30 to 60 minutes before. If the surgery lasts more than 4 hours, then you give a second dose. The idea of giving the first dose 30 minutes before is you have to reach the maximum levels when you are in the midst of the surgery. When to give more doses? Operation lasts longer, the blood loss is higher. For most of the surgeries, you discontinue prophylaxis at 24 hours. If you are continuing it for 2 to 3 days, it no longer remains prophylaxis. That means you are then treating the patient for something which has gone wrong. Okay? So after use, we come to choose. Now, the most important here is source. The pathogens for pneumonia are totally different from pathogens of a UTI. So the first site is what is my likely source, and then the likely pathogens. Then comes my choice of empirical therapy. So if you ask me what are the 3 factors to decide my empirical therapy? 1, what is the likely source of infection? Second, what are the risk factors for resistance in the patient? And third, what is the clinical condition of the patient? We should not base our choice only on the clinical condition of the patient. 3 factors are very important. Spectrum. Okay. Will it work? Penetration. If you are using aminoglycosides for intra-abdominal infection or for pneumonia, they don't penetrate much. In the recent Idsa guidelines for intra-abdominal infections, they have de-emphasized on aminoglycosides simply because their penetration in the GI is not great. So we have to know penetration very well. Should you give a monotherapy or a combination? Now, lots and lots of evidence is coming that 2 or 3 drugs are not always or necessarily better than a single drug. Okay. Look at the bugs, say secondary peritonitis. I'm talking about for surgeons. Your 2 most common pathogens are E. coli and anaerobes. So if you are doing a simple lab poly appendicectomy, I am only worried about these 2 pathogens. So why should I give anything bigger than a single shot of prophylactic? Unless it's a secondary peritonitis and patient might go into sepsis, then I have to give maybe a 2 to 3 days or maximum 5 days of antibiotics. Whereas if it's a tertiary peritonitis, which means now it has become a nosocomial infection, this is where I'll be worried about the bigger bugs, Pseudomonas, Acinetobacter, and I have to treat the patient longer. So it's very important to know your diagnosis, your source, and your likely pathogens. What is the route? Now, again, now we say more serious the patient, go for parenteral. But now we know as soon as the patient is ready to take oral, you should shift from IV to oral. It not only reduces the patient's hospital stay, the overall antibiotic consumption, but also the risk of acquiring fungal infections or other pathogens while the patient stays in the hospital. So it's very important. What to do once culture is available? Now, first of all, how much blood or the sample you send. If you're taking a blood culture, at least 20 to 30 ml in 2 different sets. There are multiple reports now which say the higher the blood sent, more is the yield of the culture coming positive. And remember, if culture comes positive, that's a gold mine. Then you can modify, de-escalate, escalate. Otherwise, we are only groping in the dark and treating patients with empirical. So it's very important to decide how the sample is taken, how much sample is taken, and what culture. If we don't want to treat only culture reports, we have to look at the patients also. Is it a contaminant? Is it a colonizer? And what is the pathogen? Now, this is one of my favorite slides. Why? Suppose it's a 2 a.m. in the night. You are in the surgical room. Microbiologist has gone home. This is the culture report you get. It's an E. coli. Now, it's very important as a physician, as a surgeon, you should know whether it's a ESBL or not. Look, can you tell if it's a ESBL or not? One of the simple ways is look at third generation cephalosporin and look at cefoxitin. If third generation cephalosporin is resistant, any third generation, and cefoxitin is sensitive, most likely this is an ESBL. In this case, don't use any beta-lactame. You have to use a piptaz or a carbapenem. Very important message. Looking at a simple culture report which only gives S, I, or R. Similarly for an MR assay, because we have to learn to say no to vancomycin. Overuse of vancomycin in ICU. The moment we see Staph aureus, it means vancomycin. That is not true. Again, look at oxacillin or cefoxitin. If an oxa or a cefoxitin is resistant, only then it's an MR assay. Only then you use a vancomycin or a teicoplanin. Otherwise, even amoxi or a first or a second generation cephalosporin is good enough for a Staph aureus. So these two I wanted to show because these are the most common to choose between MRSA, MSSA, and ESBL and a non-ESBL. So we have to know our microbiology. IDSA guidelines, I will not go into much. What they say for mild to moderate patients, use non-pseudomonal drugs. You see, because you are not suspecting pseudomonas, they are coming from the community. Patients who are high risk from community, routine use of aminoglycosides is not recommended. You only use anti-MRSA drugs if in your hospital MRSA is high. So what do you use? Then you use for high risk community acquired or a nosocomial, maybe a carbapenem or a piptaz, but nothing before that for mild to moderate infections. Third is switch, which is de-escalation. What to do on a day 3? Day 3 requires 3 factors to take 3 decisions. If your culture is positive, patient is doing well and lots of guts. So if you have all 3, what do you do to exercise de-escalation? 1, change from broad to narrow spectrum, reduce the number of antibiotics, reduce the duration of antibiotics. This is how to exercise de-escalation by the D3 formula. Don't reduce the dose. Sometimes people say, oh, I have given the patient meropenem 1 gram 3 times a day for 5 days. Now let me reduce to 500 mg BT for next 2 days. I'm sorry, that's wrong. That's not de-escalation, that's disaster. Okay. Bacteria love low dose. And then stop, of course, for most of the intra-abdominal infections, 5 to 7 days, sometimes 3 to 5 days. If it's a tertiary peritonitis or a pseudo or acinetome, maybe then longer, or the patient is in sepsis, then longer. Otherwise, for normal secondary peritonitis, for an abscess, 3 to 5 days or sometimes 5 to 7 days is good enough. For most cases, surgical prophylaxis, 24 hours is enough. This is a very good one snapshot of how to do antibiotic stewardship. So as you can see, I've divided into 2, empirical and targeted. For empirical therapy, we need 2 things: local microbiology data. It's your right as the ICU physician, as a critical care physician in the surgical ICU, ask the microbiologist, ma'am, please tell me what is growing in my hospital, my ward in the last 6 months. That's of utmost importance. Second, what I just highlighted, patient risk stratification. You need to know these 2 things to give your empirical. Then lab diagnosis, of course, send your samples well. And then finally, once you get the culture report, then de-escalate. And we have to combine all these 4 to make our hospital antibiotic policy, which can look like something like this. This is just one prototype. So patient type 1, which means no risk factors, what this patient could likely suffer from, and finally, what antibiotics to use. Patient type 2 is a kind of a ward patient. I give non-pseudomonal drugs. Patient type 3 is a sick patient, and patient type 4 where carbapenems even are not working, and then what to do in this patient. So some sort of antibiotic stewardship, a treatment guideline, a treatment charter you should have to make for your hospital based upon your local microbiology data. Low-hanging fruit, and final 5 minutes. Now, many people say it's very difficult to do AMS in India. I don't have ID physician in my hospital. I don't have clinical pharmacologist. In India, we have to follow local solutions. The criteria for selecting, and I can tell you, you can start from your own level. Look at the smallest thing that you can do. Can you move from IV to oral at day 2, day 3? Can you follow asymptomatic bacteriuria? I will not treat other than immunocompromised or a pregnant female. Can I stop double coverage of antibiotics? So I can tell you the story of this Netcare hospitals in South Africa. This is very much like Apollo and Fortis in India. They have a network of 50 hospitals. They just did 4 interventions and reduced the antibiotic use drastically. And this was published in Lancet Infectious Diseases. What they did, not more than 4 antibiotics together. Duration of antibiotics for most cases less than 7 days or 14 days, and no double cover. That means the patient is on piptazo also, metronidazole also. Why both cover anaerobes? Why to give it double? Just these 4 things. Now you don't need a hospital management to tell you to do this. You don't need anyone's mandate. You can do this in your own practice. Start small, start from small things in your practice to start antibiotic stewardship. What can industry do? Well, of course, we are working on more faster diagnostics. For me, the whole paradigm will change if we can have a pinprick test 10 years from now, which will tell me within 1 hour, what is the pathogen, what is the susceptible. Because most of the misuse is at the level of the empirical therapy. Of course, we are seeing more vaccines, especially the pneumococcal vaccine has reduced overall antibiotic use in children a lot, right? So we are producing more vaccines. And of course, these are the 7 new drugs which have come in the last 5 or 7 years. Most of them have come in US. Only 1 drug has reached India so far, which is the first one, ceftazidime avibactam. See, out of these 7 drugs, what I told you in the beginning, India's biggest problem is MBL, metallo-beta-lactamase, and acinetobacter. None of these drugs covers MBLs, although the estridiol avibactam covers. It's still in phase 3, it's not marketed. Eravacycline is not launched in India. Cefiderocol, last drug, cefiderocol, I think could be one of the colistin sparing drugs. It covers almost everything, right? But again, so far not available in India. And there is some questions on its data and efficacy in acinetobacter. But again, what I'm trying to say is that 7 to 8 new drugs have been launched in the last 5 years. Only 1 is available in India, and none of them is a panacea for everything. These are the IDSA guidelines for how to treat ESBLs. Look, IDSA guidelines, how to treat a CRE. Nowhere they have mentioned colistin. They have taken colistin out of the IDSA guidelines, and newer drugs, ceftazidime avibactam, meroweber, imirel, cefid, none of them is available in India. So I think for India, we need to develop our local solution. Our problem is NDM plus oxa, crab. We don't have cefiderocol and eravacycline, which cover NDM and crab. We don't have meroweber, imirel. We only have ceftazidime avibactam, but that covers KPC and oxa, does not cover NDM. Can we combine it with an S3OM? Perhaps RGK sir can talk about his experience on that. And then we have his colistin, phosphomycin, TG cycline. We have to juggle between this and find out. But this is at the end. The beginning starts with antimicrobial stewardship. Okay. So I'll end with my last 2 slides on antibiotic commandments. One thing is, I am glad the government of India banned these irrational combinations some 5 years ago. Look at how many BL-BLI combinations are available in India. Globally, only 5 are approved. Now the newer ones are approved, but the older ones are only 5. Piptazo, ampicillin, amoxiclav, cefosulbactam, ticarclav. In India, 25 are present. That poor ceftriaxone has been combined with sulbactam also, tazobactam also, clavulinate also. Now, as a pharmacologist, this is a mockery. How can a drug which is once a day can be combined with a drug which is 4 times a day? But everything works. I was aghast to see one drug which has 3 molecules, injectable, vancomycin, ceftriaxone, metronidazole. A gram positive ke liye, gram negative ke liye, anaerobic. So please, at your own level, at pharmacy level, avoid such irrational combinations to be used in the hospital. Ceftriaxone and levofloxacin are not small antibiotics. Please, they cause maximum collateral damage. I think one of the biggest reasons why resistance is so high in India at the community level is because our 3rd generation cephalosporin and fluoroquinolone use is very high. I sometimes say, even if Indians get their urine tested, there will be traces of fluoroquinolone. Ciprofloxacin is in our first aid kit. In Australia, you have to take an ID physician prescription to get a ciprofloxacin. Okay, so we have to be conscious while giving these drugs. Learn to say no to vancomycins. Staph aureus does not mean vancomycin. Only for MRSA you use this drug. Don't use vanco for sensitive staph. Avoid bacteriostatic drug in immunocompromised or septic patients, which I think is a common knowledge. Pip, Tezo, and Carbapenems are good as monotherapy for anaerobes. You don't need to give Metrogyl for every patient. It's not a birthright of every patient who's in the hospital to get Metrogyl. This is double coverage. And finally, VIPs don't need 6 antibiotics. Don't give 2 beta-lactams together. Patient is on Pip-Tezo also, Carbapenems also. What is the value? Nothing. Nuisance value. Whenever you have to combine 2 drugs, change the mechanism of action. Don't combine 2 drugs with the same mechanism of action. Beware of irrational, illogical combinations. Antibiotics should not cover up for an absent infection control. This is a very common logic sometimes built. I have to give 3 antibiotics because my infection control is not proper. I am sorry, that's the reverse logic. Let's adopt a culture of sending more cultures. We normally say, man, culture to kabhi positive aata hi nahi. I am sorry, if you do not send appropriate cultures, they will never come positive. And some people say, I don't believe in my data. Well, then don't send cultures. Some data is better than no data. So please, we have to learn the art of knowing our cultures. Trust the microbiologist, local data is supreme. This is not myocardial infarction or asthma that the entire world will follow one guidelines. You can't even copy guidelines from the neighboring hospital. We have to make our own guidelines. Risk stratify patients. Not everyone needs a gorillamycin or a king Congo penicillin, right? And finally, winning horses can be changed. De-escalate. The moment patient is stable, you have a culture report in front of you which is positive, de-escalate. So I believe, yes, there is light at the end of the tunnel, but if we do not take any corrective action now, it could be of an incoming train. Thank you so much for your patient hearing. Questions, suggestions, criticism, everything is welcome.
Ankur, if you could just stop sharing your screen.
Yes, ma'am, I'll stop.
Over to you, Dr. Ram Gopalakrishnan.
Yeah, thank you, Ankur, for that exhaustive review of infectious disease therapeutics. In fact, you covered the entire bacteriology aspect of clinical infectious diseases. That was very exhaustive. I don't see any questions in the chat box. So please feel free to type in your questions so that I can ask Ankur what he feels. I'll just get this going. Ankur had a comment on Aztreonam, correct? He wanted to ask, yeah. So this drug that we have, ceftazidime, avibactam, is not effective against MBLs, as Ankur said. So what we do is we add on Aztreonam, we infuse it at a separate site, but at the same time, so that the Aztreonam will take care of the metallo-beta-lactamase while allowing the Cas-Avi to do its job against other type of carbapenemises. Obviously, this is a short-term solution till we get Aztreonam, avibactam in India. But till that point in time, we do this. Obviously, it adds to the cost of therapy. But this is a fairly effective colistin-sparing approach that we take. You can also confirm whether your drug is active in 2 ways. One, you can do a molecular test on say, a flag blood culture to see what kind of enzymes it has, so that you can predict whether the combination is going to be active. And secondly, you could do testing in the lab. If it is resistant to Cas-IV, you could do a synergy test with Aztreonam to see whether there is an effect there. So yes, it is an option in especially for empiric therapy before you know what you are dealing with or the mechanism of resistance.
Yeah, thank you, sir. Thank you.
Yeah. Dr. Reba, your comments, please. You're muted, ma'am. You have to unmute yourself.
Yeah, as usual, Dr. Ankur has done a wonderful job in discussing the A to Z of antibiotic resistance and therapy. And I would actually like to reiterate one point which he brought out, which was based on a small incident in a government hospital in Delhi, where despite the ceftriaxone resistance being almost 70%, the clinician said that they did not have ESBL. which actually is, it opens up a Pandora's box. And I'm glad he took it up, because the onus of informing the type of resistance or the susceptibility pattern lies as much with the microbiologist as with the clinicians. There are two things here we have to keep in mind. One is the microbiologist must, and I'm glad that the later microbiologists, the younger generation, is coming out to be more proactive and informing and communicating with the clinicians or the treating physicians. But it is very important that the microbiologist is the person who actually picks up the antibiotic resistance first. And therefore, it is they are morally bound to convey this to the treating physician. And I'm sure Dr. Ram Gopalakrishnan will agree with me that a communication between the microbiologist and the treating physician is essential for rationalizing antibiotic therapy. And in this context, actually, one, of course, is the knowledge the microbiologist must have with regards to its in vitro, in vivo activity. Second is there is a concept known as selective reporting. Like you don't report every antibiotic, whole panel that you have put up and straight away send it, so that without giving the importance of each one of them. And third, of course, is communicating with the clinician. So I think microbiologists also have a paramount important role in containing antimicrobial resistance. And I'm glad Dr. Ankur brought this out. And I hope the microbiologists will take this up and become more communicative. That's what they should get out of their labs, and communicate with the clinicians and try to discuss the pros and cons. The other thing which Dr. Ram told was that, testing for synergism. This is a concept which actually is very important, because if we do not do the antibiotic, we just have a panel of antibiotics, but we do not report what are the outcomes of this. It's not just saying sensitive, intermediate, or resistant. Whether there is any synergism, antagonism, these are some of the things which should be conveyed to the clinician in order to make therapy, rationalize the treatment. And thank you, Dr. Ankur. It was really wonderful talk, taking us through the whole concept.
Thank you.
Dr. Malini is also a microbiologist and she's logged in. Malini, would you like to say something? Some questions. Dr. Anil Kumar, would you like to make your question more clear? In what situation do you?
Yeah, I think his question is on monotherapy colistin should be used or not, right? So maybe I think I will let RGK sir answer, but I think what we have known so far is that we should avoid giving colistin as monotherapy, because hetero resistance develops very fast to that. This was not a great drug ever. It was launched in 1969, but we never used it. So the question is, what do you combine your colistin with? That will also depend upon the pathogen, right? According to the latest guidelines, maybe for Pseudomonas, you don't need to combine, but for CRE, we need to combine our colistins. But also you need to know your MIC values, right? If you want to combine your colistin with a carbapenem, then if your MIC of carbapenem is between 8 to 16, that means intermediate or not very resistant, perhaps you can combine a carbapenem in high dose and then colistin. For Acinetobacter, you can combine it with maybe tigecycline. Sometimes we combine for CRE with fosfomycin also, and sometimes in Pseudomonas. Most of the cases, these are the drugs that we combine colistin with. But again, ask your microbiologist, don't give me SIR, tell me the actual MICs before I add after the culture report. But RGK sir, I guess you are the best person to answer this.
Yeah, that is a difficult question to answer, because if you look at guidelines, both European guidelines and the IDSA guidelines, which Ankur showed you, they recommend that colistin should be used in combination. But the question is, what do you combine colistin with? At times, you have an antibiogram that is very, very resistant and virtually nothing else is sensitive. If you have an Acinetobacter, you could use sulbactam, even though you don't have sensitivity testing for that. That is recommended by both the European and the American guideline. But for other organisms, there is no evidence that combination therapy is better than monotherapy. So even though we know that colistin is a poor drug, sometimes we are stuck without alternatives. But it is true in general, try to use colistin as combination therapy for more severely ill patients, especially systemic infections outside the urinary tract.
Yeah, RGK sir, since we are on the question of colistin, one important question is also, and I don't agree with that, but I want to ask you, many people say when I combine colistin with something else, I don't give the highest possible dose of colistin. Is that the right approach? According to pharmacology, I don't think so, but still I want to hear from the clinician.
Actually, you should probably use a higher than usual dose. Because if you're dealing with a multi-drug resistant organism, you need the highest drug that will avoid toxicity. Colistin has a very narrow therapeutic index. Some people feel, especially the American CLSI feels that you should never use colistin. You cannot get therapeutic drug levels to inhibit the organism, especially in the lung. So if you use colistin, please use the highest possible effective dose, never a low dose.
Thank you, sir. Thank you.
Dr. Anil Kumar, you're trying to say something?
Actually, I totally agree that this colistin monotherapy should not be used, especially in Indian scenario. But I especially feel that the dosing issue is still very pertinent in Indian ICUs, because what we have been seeing and observing, patients are receiving a very low dose of colistin considering the either kidney impairment or little bit of mild derangement in creatinine. And even that combination, people are using meropenem along with colistin despite the available antibiogram or MIC values. It is like, even I have seen patients being on monotherapy of colistin. And even the concept of loading dose, some clinicians don't accept, because what I feel, a good dose of loading dose of colistin is actually required, especially in a sick patient.
Your comments, Dr. Ram Gopal Krishnan.
Yeah, I agree with that. Those are all valid comments. Always use a high dose. That's not true. That's true not just for colistin, but for any antibiotic. If you're dealing with a severely ill patient, you should use the maximum recommended dose. There are many reasons for that. ICU doctors will know about increased volume of distribution in sepsis, especially of water-soluble antibiotics. So colistin is no exception to that. You should use a high dose. And I agree that in practice, it is widely underdosed for fear of toxicity. That's part of the problem with this drug.
Yeah, I'll just add here. I mean, there was a graph which was published, I think 5 years ago, I think, which totally changed the paradigm for colistin dosing. That time, most of the ICU people were using 6 million units per day, 2 million TPIP.
Yeah.
And it showed that it takes 48 hours for that dose to reach the MIC level. That means for the first 48 hours, it was like a candy, bacteria were enjoying it. Right? You have to give a 9 to 12 million loading followed by 4.5 million BD. Because now we know PK/PD of colistin is complex. It's more of a concentration, less of a time dependent, right? So it's very important to give. And as sir said, all drugs, even if the patient is in frank sepsis, hyperdynamic state for 48 hours, he's peeing whatever you are giving. So if you give further less dose, it does not reach that therapeutic level. So first dose should always be the highest.
Yeah, so while we're on the subject of colistin, I just want the audience to know that the world in general is moving away from polymyxins. Both the recent guidelines, one is in 2020, one is in 2021, emphasize that wherever possible, you should use an alternative. For instance, if a beta-lactam will work, use a beta-lactam. It is only in a situation where a beta-lactam will not work that you should even consider colistin. So in my practice in the last 2 or 3 years, I use at the most 1 dose or 1 day or at the most 48 hours of colistin till my culture is back. I make a conscious effort to move away from colistin wherever there is an alternative. And in the majority of situations, there is usually an alternative antibiotic which you can use for that patient.
There's another question on the chat box. Dr. Ram, would you like to take that about piptas?
Let me see. Yeah, so the question is, piptas is used as empirical therapy in most hospitals in India. And yeah, so there's a couple of issues with piptas. First of all, piptas is no longer recommended for a bacteremia caused by an ESBL organism. There was a large trial published 3 years ago called the Merino trial, which showed an inferior outcome in these patients. So if I'm talking to a surgical audience, what would I tell a surgical audience? If you have a very sick patient who goes to the ICU after a bad appendix or a bad perf, give that patient a carbapenem, because carbapenems are the most reliably active drugs against ESBL producers. If your patient is in the ward with adequate source reduction, then you could give that patient piptaz. So piptaz really has had its day. It really should not be used for empiric therapy anymore in sick patients. It is more a drug to be used after receipt of sensitivities or for de-escalation in a relatively stable patient with a low inoculant situation, both microbiologically and clinically. So that is true. Piptaz will see fewer and fewer indications. Certainly for empiric therapy, its time has come and gone.
I'll just add, whenever you use piptazo, give 4.5 grams 4 times a day in 2 to 3 hours infusion. Don't give 3.75 gram TDS in 30 minutes infusion. So just try to optimize its time-dependent characteristics.
Right. Radhakrishna, you want to say anything?
Actually, I think surgeons are the most indisciplined persons when it comes to antibiotics. They somehow tend to believe that you have put a knife to a patient, it should always be some antibiotic should go in. And I don't know, there's always, I thought there's a love-hate relationship between ID people and surgeons all the while. I think there were certain guidelines while I was working with Dr. Ram Gopal Krishnan, but by and large, we do not know where we need to involve an ID physician and where all we can, use antibiotics on our own. There should be, some definitive criteria. But it's very interesting to know that only 50-60 ID people are in the whole of India. That is, there's a very precious species, I should say. Dr. Ram to respond.
Yeah, there are about roughly about 150 species. So we are slowly proliferating at a very slow reproductive rate. That is true. So I can't agree with you more. We certainly need more specialists. DM in infectious disease has been introduced in about 4 or 5 hospitals across the country. We have a national board program as well. But these programs churn out only about a maximum of about 20 to 30 specialists a year. So it's a big supply issue, I feel. So,
regarding the point where we can do the antibiotics ourselves and where we need to involve you.
I think it's quite simple. If you have a patient whom you're doing a surgery and things go well, you certainly don't need an ID doctor. You just follow your routine prophylaxis protocol in your hospital. When things go wrong, for instance, you have post-op sepsis, you have post-op abscess, you have post-op something out of the ordinary, then that it's reasonable to involve an ID physician. Certainly for a more complicated case, the more complex your surgery, the greater the risk of a poor outcome. So it's just an individual decision-making process, and also depends on availability. There should be an ID physician at your center for you to involve them. So.
No, but I also understood that certain groups of drugs can only be prescribed by an ID physician to keep things under control in a hospital.
I think if you're an MBBS, you can write whatever you want. That's what the law in India says, and that is part of the problem. But yes, the concept of restricted antibiotics is something that can be used in a public hospital system. In a government hospital, the HOD can say, only I can give this antibiotic. You cannot do that in the private world, where typically we follow a different system. We allow all clinicians to use whatever they want. And then 48 hours later, we do the stewardship to kind of try and justify, why are you doing this? Can we stop this? The culture is showing this. Do you want to switch to something else? That is a typical system, which is much more easily implementable. So often we end up giving more antibiotics than we need to. So we need to strike a balance there.
One other point I should say as a surgeon, is when our surgical patients in the post-operative period get followed up by the ID clinicians. ID clinicians look at the bottom of the patient or semi-open abdomen and say, oh my God, such a big wound. Then the patient thinks that something seriously gone wrong. To surgeons, it's not very big, but I don't know whether you have come across situations. We come across these situations quite often. So the patients come back and said the ID person is aghast seeing the wound.
We try to carefully hide our emotions from the patients.
No, I think you should have team rounds and explain. You should you should make an ID person a part of your team so that they know. I mean, most of them are looking after medical patients, so maybe they need some kind of introduction to surgical patients.
Yes.
In fact, there are a lot of intensivists who are not very comfortable looking after post-operative patients. They are so used to handling medical patients, so they need some orientation. So yeah, that. So Ghosh, would you like to say something, Amit Ghosh?
It's all that it's a fantastic session. I think if anything COVID has done, it's probably going to increase the number of infectious disease doctors that we need and clinical pharmacists. Education is key. We have to go beyond the eminence-based medicine to evidence-based medicine, and the microbiologists in many big hospitals have created what is called heat maps, where you can look at a hospital, and these are public data, to see what is the resistance pattern, and the public can see it and decide whether I want to bring my father or mother to your institution or not, based on how carefully you manage it. But having a respected infectious disease doctor, which I use quite frequently early on rather than late, is one of it is face-to-face consultation, another is just lifting up the phone and asking for advice, is kind of very important. Education is key, and for our American Board of Internal Medicine, unfortunately, they have classified each section of medicine, like cardiology and all that. There are about 15-20% of the question, and infectious disease becomes like 5 or 10% of questions. And that too, maybe you'll have 1 or 2 questions on antibiotic resistance. So it becomes a problem for institutions. So what we have done here in Mayo is we have periodic requirement for every provider who does hospital care and outpatient care to go through these kind of education. And I must give a loud shout out for Ankur for doing such a superb job. I think I need more time to understand and capture all the things that you mentioned. It's very saturated for one lecture, but so this has to be, I don't know about the Indian scenario. If you have 150 infectious disease and thousands of hospitals, who is doing the education? Is it the surgeon, or who's looking out for the patient, in fact? And why don't we have more Ankurs, clone him and put him in many other places in India? Because is going to be more important. But the other thing which has been coming out is that using other risk modifiers or risk assessments like procalcitonin, which has come up. There are pluses and minuses. And now for COPD, we are also using CRP. A paper came out in New England Journal in 2019 about using CRP. If it's more than 40 in those patients with COPD, you definitely give antibiotics. Somebody's CRP is less than 20, you don't give. And 20 to 40, you kind of decide. So these are some kind of biomarkers which are coming up. But I have to kind of admit that a lot of what Ankur said is not the blame of medicine, but it's a lack of, it's just showing the progress we have made in understanding pharmacokinetics, team-based medicine, and it's a progress in the right direction. And yet we might blame the family practice doctor or the internist or whoever is in the is working in the villages where nobody wants to go and practice, and they have to save these patients. They have to give all these antibiotics. We do blame them, but they have nothing else to do. Nothing else, no other risk assessment, no extra help, or no ID physician to kind of get to that point. So I think a lot of it is we put the horse before the cart situation, and that's a work in progress. It's not an easy solution, but it's a leadership solution for hospitals to absolutely use a pharmacist, a clinical pharmacist, an infectious disease doctor in the decision-making process to understand, and a microbiologist, and have good communication. There can't be any ego clash out here. We have to be ready to listen from a clinical pharmacist to be ready to change. And that's what it is. So it's not going to be an easy solution. That's why there are so many guidelines, so many antibiotics come. Whatever was the choice of antibiotic yesterday is not going to be the one we are going to use tomorrow. And we can be criticized for doing that, rightly so, but it is how the knowledge is advancing. Having said that, there is no excuse for big hospitals like Apollo, Fortis. I'm sure you have a lot of them. In Chandigarh, when I was practicing there, along with Ram, we never had an infectious disease doctor there. If Ram would remember, we had to do it all ourselves in a tertiary institution. So these things were not there 20 years ago. But now there is no excuse. So everybody has to ask why not. And I know why not. It's a very, very hard job to be an infectious disease doctor. It's one of the lowest paid specialties in US. High demand. Fortunately, COVID has brought up the reputation. And so I think we'll see some movement there. But as far as the salary difference is there between a cardiologist who in the calm atmosphere just puts a stent and gets all these money, and an infectious disease doctor who has to look at the open wounds, which Patta said, and has to come up with all these antibiotics, constantly looking things. And the industry is also not helping them in any way. In fact, if anything, there's restriction, there's legislation. While there is no restriction and legislation when it comes to cardiology drugs and other things. Fortunately, we had to repurpose drugs for COVID and we got away with it. So there's a lot, it's a lot of hardship to infectious disease doctor other than passion and interest in this field. It's hard to motivate an internal medicine doctor to join this field if there is pay disparity. So there's a lot of issues. Everybody wants to be well taken care of. Everybody is going to send Dr. Ram Gopalan a lot of gifts when their family members are saved, but nobody is going to give him credit when it's peacetime and there is no upheavals and nobody can. Then everybody is going after the cardiologist and oncologist. So this is the disparity we have to face in a hospital, and only leadership can decide what is really important and why is it important. Never to leave your eye of the ball. You have to have a Dr. Kanangu and you have to have a Dr. Gopal Krishna. These are people who cannot be disposed with, cannot be an afterthought. These are requirements. And I thank Ankur again. You need to get to the Indian panel and keep talking about it. And as they say, if it's a folk song and it's good, like Beatles or something, keep singing it. Keep doing it more and more and more. Drive it home. Get all the people and drive it home. Just like the first person on sepsis, I'm forgetting his name, the surgeon, who would go from door to door, purple sepsis, and nobody would believe him. And they put him they thought he was a madman and got him out of the hospital. And he was the gentleman who said just hand washing would prevent purple sepsis, as simple as that. I have the highest of regard for my infectious disease colleagues.
Your closing comments, Ankur.
First of all, thank you, Dr. Ghosh, for your exalted words. I totally agree with that. I mean, I think for me and for generally, I think antibiotics comes again to the passion. I think teaching antibiotics, I know it's a very boring thing, but I think what paraclinicals like myself, pharmacology, microbiologists, I think we also have to take the onus. I always tell the microbiologist or the pharmacologist, if you have a 9-to-5 job and then you want to be taken seriously by the clinicians, forget it. You have to be ready to do the morning and evening rounds with them. You have to know your clinics. If you just tell them what is time dependent and concentration dependent, don't tell them the clinical value of it. I'm sorry, no one will be heard. So I think it's also upon people like us, paraclinicals, to again take more mental in the absence of ID physicians. We have only 150. In rest of the world, clinical pharmacists plays such an important role in stewardship. It's run by a clinical pharmacist. In India, the pharmacist is only there to dispense the drug. So I think there are many people who have to double up who have to assist clinicians, who have to be ready to go beyond the call of their duty to save antibiotics. So I always say in my closing comments, there are 4 things we have to give to the next generation: clean air, clean water, fuel, and antibiotics. And all 4 are in danger, right? Especially after the Ukraine war, even fuel is in danger. So, but I think some of us can, I think we really need passionate people to save this most precious class of drugs so that we can pass antibiotics to the next generation. I again thank all the organizers for giving me this podium for second time. I hope I can come again. I hope we can learn from each other. And thank you, RGK sir, once again for being on the panel and for guiding us. Thank you so much.
Thank you, Ankur. Thank you, Dr. Ram Gopal Krishnan, and thank you, Dr. Reba, for joining us. Thank you all for logging in and staying in for what Ankur said was a boring topic, but I don't think it was so, because almost everyone who logged in stayed up to the end. We'll meet again next week with yet another episode of Marvelous Medicine. Till then, take care and stay safe. Good night.